impact the community in a positive way and help the trajectory of kids' lives. So really excited to talk to you, and hopefully have some really good discussion about concussion as well. So should have a handout or some information that I sent on ahead of time. So this should be a pretty similar talk to what you have. I don't have any financial relationships. Insert bad joke about not having any. So we're going to go through these main things. So we're going to look at the background, kind of epidemiology and such. We're going to look at clinical presentation, diagnosis. We're going to look at some of the ways that we manage this, kind of assessment on the sideline and then management in the clinic. And then we're looking at prevention as well. And then we're going to look at also as well how to look at, we have a multidisciplinary clinic at Children's for more complex concussion, and how do you refer to that clinic. So the background on concussion, so background on this is really concussion is an injury that's as old as time. This is a very well-known injury, and it can happen for a long time, but we live in a different world today. And a lot of that comes with the kind of the legality, the issues surrounding concussion that you see from the top level down. So at the NFL, NCAA, and high school football levels, we're seeing increased lawsuits and all this, and it really kind of has changed things. But over the past 10 years, there's been changes in a good way that with legislation that's coming in to really protect athletes. That's been adopted now across the country. All 50 states and DC have that legislation to protect athletes with concussion. And so we have our own in Wisconsin. It's called the Wisconsin Sideline Safety Act, and that's been going for years now. And it applies to all youth sports participants that are less than 19, so the pediatric essentially age range, and its oversight is through the DPI. And really there's 3 action steps, and this is very similar to most laws across the country. One is education. So at the beginning of the year, the season, or so on, they're going to get that information, hopefully parent, athlete, coach, all look at this education about concussion, have an awareness of what's going on. And then if someone does have a suspected concussion, then we want to have immediate removal from play. And then finally, that 3rd step is that clearance to go back in. And the clearance part of it, you have to be someone who is able to practice and comfortable with concussion. There's not a lot of teeth into like it has to be a physician versus an APP or a chiropractor even, but there needs to be someone who is really comfortable and able to take care of a patient with concussion. So you might ask the question, has this legislation been helpful? And I would say it has. And so there's just several studies, I'm not going to go through each one, but several recent studies that talk about the improvements, I would say, in awareness because of the increased numbers. Do we really think that over the period of a few years that the number of concussions increased? No, but probably what increased was the amount of concussions identified. So you can see that from that that Washington State study. And you can see on these other studies as well that there's improvements. And if you look at that Crispin study there in 2014, you can see that there's been a positive impact there as well as it regards concussion or education. So this is important as well, but there has been a typical trend. Football is kind of where all the buzz started. And you can see that football education, there's still a little disparity between just football and other sports. So we need more education. Fortunately, though we live in this heightened world of legislation and concern about concussion, we have a lot of guidance. So that's one thing that's changed as well in a good way over the years, is we have more guidance than we ever have, and that body of evidence on how to manage concussion is growing. So if you haven't checked it out, this is something freely available online. It's the Berlin Statement. And this was published early last year in 2017 after they met in 2016. And so one of my colleagues at the medical college, Dr. Michael McCrae, he's been a part of making these statements over the years, Zurich and on back. And he is a leader in research and is at the medical college. And I've had the privilege to work with him in clinic and see patients with him in clinic in the past. So we have some really good evidence, getting better, I should say, and there's a good source to go to. So let's look at the background, or epidemiology. We don't really know what the number of concussion is. I'll just say that first off. But this recent paper showed that about 1.9 million sports and related concussions were happening a year. So that's a lot. And you can find numbers that are a little bit bigger, but you'll find that some of those numbers include other types of concussions. This is really paring it down to concussions that happen essentially in the pediatric athlete. And then you can see that the sports-related concussion ED visits has gone up more than doubled in age 19 or younger. So we know that there's something going on here. And again, is it awareness? Yeah. Is it potentially more concussions because there's more kids playing sports? Probably so. And there's probably more than that too, more reasons than that. But we're seeing increasing concussions showing up in ERs, in clinics, and you can see many of them are sports related. And we're seeing even that there's a difference between, that intense competition when the adrenaline's kicked up versus practice. We see more in competition versus practice. We also see in sports, like specific sports, the collision sports are of course going to be the higher. It makes sense they'd be the ones that you see higher rates. And if you look at the other sports that are more high contact sports, you see quite a high rate in those as well. Interestingly, it seems like it's held up in literature now for some years that girls are seemingly having higher rates of injury in paired sports. So when you can pretty much say the sport is the same, it seems like the girls are getting more concussions. Now, is that because they're reporting more? Could be. Nobody knows for sure, but it seems like that rate is holding up. As far as mechanisms, we see that player to player is the number one reason for mechanism to get injured, and then player to playing surface would be the second, and then there's others that kind of round out the rest of that. Recovery, and this is what really I think hits home for my patients, is that when we're dealing with the pediatric population, we're seeing that athletes take longer to recover. And I've had to change my slides over the years. I've been at the medical college since 2011, and I've had to change my slides on this over the years because we used to say most people really did recover within, was it 7 to 10 days or so. But in pediatrics, the literature, especially over the last 5 years or so, has said this is getting pushed back longer and longer and longer. And so what I more or less tell people by now is, it's probably about 50-50 that you're going to be recovered, at 2 weeks. And so because we think we're capturing more people that were maybe lying in the past, or who weren't being honest or straightforward or explaining away symptoms. And so we say kind of the 50-50 line is around 2 weeks now. But you can see that 20% may take longer than 30 days to get better. And a lot of that comes out of ER samples. I actually just recently published online our study at Children's Hospital of our retrospective chart review. And we found that people referred to our clinic, now take it for granted they get referred on a median of 11 days out from injury, are taking longer than 30 days on average to get better, around 40 days actually. So that's a biased sample, but still there's plenty of kids out there that are taking a month or more to recover, and that's kind of the main point there. So this can have a profound effect. Yeah?
What age, are you using a hard 18 years old for youth or puberty? Or
essentially up to 18. Okay. I think our particular study looked at pretty much ages of 10 to 18 in our clinic, because that's mainly what we see. And then if you look at those pediatric ER studies that have come out, they're pediatric hospitals. So you know that they're more or less in that age range. Yeah?
I'm sorry, you said that they're not getting to your clinic until about 11 days?
So that's a median, right? So there's some people that they've been managed by their primary, and I know there's a handful, right, of various family doctors, probably some pediatricians and different here, yeah. So, I think many people manage their concussions for a while, and then what's the point that you send them on to that combined clinic? A lot of our patients are referred after they're not getting better.
Okay, so I'm sorry, your study is not dealing with the folks that are necessarily being seen at 2 days and getting referred on. It's only the folks that are...
It was all comers, everybody who came to clinic. So we had some people looked us up on the web and they were there day one, after their concussion, or day two, and then we have others that they were symptomatic for 6 months and they came in. So yeah, good question. So anyway, we know that when things aren't going well for kids, it can really have a profound effect on them, socially, academically, behaviorally. We know that incidence of depression and bringing the smartphones discussion and everything else that's going on, bullying and social media. I mean, this is really can become a snowball, and so it can really be we want to try to get them get them better as quick as we can. And then there's the whole issue of more concussions, increasing risk. And some of the data is a little spotty on some of these, but it really looks like more concussions are likely if you have a concussion and keep having concussions. So we say concussion begets concussion. There's some questions for prolonged recovery. Certainly we don't want to see that. We don't want to see like the second concussion, takes, the first one's a week, the second one's 2, the third one's, 4 weeks. We don't want to see that happening. That's kind of a red flag, but there may be some risk in that. And then we see incomplete recovery where someone didn't get better because they didn't quite go through all the processes that they need to, and that's a risk. And then of course these other things that are getting more and more traction with the literature, academics, cognitive harm and psychological harm. There's some studies on that too. That kids that have concussions might have a higher risk for depression or mood disorders. And hard part is that some of those kids might have already been having those symptoms, and then they had the concussion that brought it to the forefront. So what is this concussion? It sometimes seems like, okay, we're talking about an invisible injury, and it's sometimes hard to grasp, especially for families. But we're really talking about a traumatic brain injury, but it's biomechanically induced, and it might be a direct, most of the time I think a direct blow, but sometimes an impulsive force or like a whiplash type force. And I kind of describe it like this blackout here that happened in 2003, one of those, I think the second largest blackout at the time in the world. It happened in the northeast United States. It's kind of like there's a discharge of those neurons, things aren't quite working well, and things are dysfunctional. And so I also kind of try to say, like, okay, it is a functional injury mainly, but there is some microscopic injury going on at the cell level. Then more on a patient level, kind of what is it? It's a brain injury without bleeding or bruising. It's not always a hit to the head. It's temporary, but you can't predict its duration. And you may only show symptoms and not signs, which is hard sometimes. So that's pretty easy, right? Not that easy. And so, for some families, they really want to get a little bit more into the pathophysiology of what's going on. And I think it's good to kind of have this to know kind of what's going on there. And Giza, who just recently came and talked at our concussion day at the medical college, he's from California. He came and talked to us about, some of his stuff, and he's done research on the neurometabolic cascade. He's kind of known for that. And you can see like the changes that happen over those first 10 days after a concussion. And so, you'll see that on that kind of the bottom side of the graph there, where you don't have the glucose and cerebral blood flow like you should, and that extending out to the 10 days. This is something that we think may actually even go on a little bit longer in kids. Okay, that's like a pretty significant power outage. That's a pretty significant decrease, a hypometabolic state, I should say. And so if you even look at this slide from 2006, this study by Mazarian shows that a mild head injury on a PET scan doesn't look much different than a severe head injury on a PET scan. And there's clearly increased severity there, but if you just kind of look at that, you see that, wow, that is really a low energy state that's going on. And so I think that's something just to keep in mind as you explain it to your patients. And what I like to just talk about with teenagers, because it seems to resonate with them, and kind of is as I talk about their room being messy. So a lot of the teenagers like, yeah, my room's messy. It's messy a lot of the time. I'm like, well, your room's concussed. Your room's concussed. There's things in your room that are not in the right places where they're supposed to be. It's kind of like the glucose. It's kind of like the blood flow. It's kind of like the neurotransmitters and the electrolytes. And guess what? You can clean your room. If your mom and dad said clean your room, you can do it, right? But sometimes it takes an hour, and sometimes it takes 15 minutes. It just depends on how bad it is. And they kind of get that and just say, look, your room's not broken. Your things in your room aren't broken. They're just a little out of place. And so it just takes some time for that. And they seem to get that pretty well. So let's look at the sideline real quick. Sideline, that's not my expertise. We have some athletic trainers here, right?
Yes.
Okay, yeah. So you guys, you should give this talk, really, not me. But the sideline stuff is stuff that you just really want to take care of these people and make sure that we're not missing anything big, and that we're playing it safe, I think is probably the way to say it. So especially in the pediatric populations, even more so than the NFL. They have all these protocols now and all this money, but we have to just make sure that we err on the side of safety. So I have a high index of suspicion. Remember that less than 10% have loss of consciousness, less than 30% have amnesia, so these really dramatic signs. And we have some really good tools to guide. So the SCAT-5 is the tool that came out of that Berlin statement. And so we have that. It's an updated tool. And there's actually a PEDS, or a child SCAT-5 as well, so that's really nice. And then, of course, you want to remember airway, breathing, circulation, the C-spine. Those things are life-threatening, of course. And then always activate EMS if the situation's emergent. So I won't get through all this, but you can see with the SCAT-5, and it involves a lot of things. You have to have done this a few times to do it quickly. I think it says on there you should really get through it in 10 minutes. Does that sound about right?
Yeah.
I'm not sure I could, but I'm not doing it every day. But still, this is a lot. A lot to go through, but it's really a good tool. And we use some of these things in clinic as well. Here's the child SCAT-5, so you can kind of see what the differences are. It's more child-friendly as far as how the symptoms are described. There's a child and parent rating. There's days instead of reverse months order. So if you have to go backwards, December, November, on the regular SCAT for the kids, they do days of the week. There's been evidence that even high schoolers don't always know the months backwards. So you wonder if maybe that should have just been on the SCAT-5 in general. But, I had this valedictorian the other day in the clinic, actually yesterday, who struggled to do the months backwards. And mom's like, oh, I don't know if she really knew the months forward that well. I was like, oh my goodness. I've got a 4.0. Anyway, so maybe that's smartphones and everything else. But so there's this child SAC, which is the standardized assessment of concussion. So it's a little bit more child friendly. A reading test. So that's a way, like, just have a child read something simple and see how they do with that. And then there's a single leg balance test only for the 10 to 12-year-olds. So 10 and up, you do the single leg. Below that, you don't, because they just don't have that coordination control to do that. So signs and symptoms, we're not just going to belabor all this, but you can see there are many signs and symptoms of concussion. And so each one can present with a different flavor. These are the things on the sideline that you're really looking for to make sure, okay, this person needs to go to the ER. They need to be seen right now. And you have to make that call about how bad, Of course, someone who's completely out and you're going to check on them, okay, we just need to get them taken away, make sure that the C-spine's okay, and they'll come to hopefully soon, and then as you get them, get them boarded and get them off. But again, this isn't my expertise, but these are the things that really you're looking for to make sure, And I've been on the sideline. I always, really appreciate the athletic trainer I work with, because we just have a kind of a partnership to say, I'm here to support you and make sure that we can make the right decision for these athletes. So what do? We remove that athlete from play, no return the same day, avoid that second impact syndrome, which we know is in the literature and seems to happen mainly in the really in the pediatric population. Want to make sure that watching them close. I think a good point here is if there's anyone that you feel like is concerning to you and how they appear clinically, that you think that someone should wake them up overnight, and you should just send that person in, because there's really no good evidence that that's a good thing to do at home, and it's likely just to make them have bad sleep and a longer recovery. So avoiding alcohol, we know that the young population, they're not legally able to drink, and they shouldn't be, but we know some of them are, so of course they shouldn't be doing that, because that's not helpful. It can really confuse and cloud things, as well as marijuana and some of these other things that kids are doing can really make it confusing about what symptoms are coming from what. The prescription and non-prescription drugs, this is tough. Of course, at a clinic, I prescribe things, but from the get-go at the sideline, you really want to try to discourage and say don't do these things. But you can use, acetaminophen. I think is fairly safe, and that's recommended by the Athletic Trainers Association. No driving. I think it's just you don't want a drunk driver out there because they're concussed, and they really are acting like a drunk driver if they're really concussed. So. And then ultimately they're going in or they're getting checked out and going through a protocol to get cleared. So we'll move into the clinic. This is really more my bread and butter, what I do every day. So kind of how we evaluate them and manage them. So basic principle is every patient's different. And then the other ones are that they take longer. We talked about that. You want to try to avoid a lot of stress to the brain, but really avoid overdoing that. You don't want to do cocoon therapy. That's something that has been practiced even in up to recent years where, okay, someone has a concussion, we need to decrease or eliminate all stimuli. I think of like a dungeon where someone's like in there with the lights off and like there's a little slot to hand like bread and water through. That's not going to be helpful for a patient. I mean, that's a form of punishment, right? Solitary confinement. So this is not what we want. But we also want to make sure that if the patient's not getting better, we're not seeing improvements, that we push. Like we're going to have to do some pushing for some people. Like some people just need a push, and the longer they go, the more pushing is going to be needed. So we're going to try to reduce the symptoms and promote recovery and do that however we can. It's more of a recipe than an equation. And so we look through these things like the concussion history to kind of help us know where this is all going to go. When and how many, what happened, how long the previous concussions taken, what's the intensity, has there been any complete recovery, which I think I mentioned briefly as well. We're also looking at kind of what things they might have been taking, of course, as it kind of relates to their medical history, what things could potentially interact or cause issues, or what symptoms were being treated prior to the concussion that maybe didn't come to light, like migraines or so on. Sports history, again, we're really trying to figure out what the expectation is. When a family comes in, there's so many kids these days that are so competitive, and they're all shooting for that college scholarship or to play even some in the pros, and so trying to grasp what expectations, what kind of stress are we under, what's perceived expectations, what's like real, where are we getting all the stress, and what's going to impact our recovery. Here's some things that have some evidence behind them, regarding risk factors for prolonged. So a prior concussion, I think I mentioned that, younger age, Female actually shows that as well. So we talked about female gender with risk of increased severity or incidence, I should say. And then there's also potentially some evidence, including our own study from our retrospective sample, that showed that the gals took longer to recover. So we don't, again, know why that is. Again, is it being more intuitive, more perceptive of symptoms? Hard to say. History of mental health disease or disorders, or headaches, learning disabilities like ADHD, cognitive attention problems, prolonged LOCs and PTA, as well as altered mental status for long times. We're seeing more with dizziness and motion sickness. So I ask almost every patient now, like, do you have a history of being sick when you take long car rides? Can you read in the car or not? And then I know a little bit more if I need to get them into some therapies, early on. Post-traumatic headaches and fogginess all have some evidence behind them, or in migraine. So these are just the quick rundown of what presents most commonly. Headache is by and large, the number one, but just be advised that not everybody will say they have a headache. I find it's pretty rare, but according to a study, like, maybe up to 10% or more. So what do we do in clinic to assess them after we've gone through that history is a comprehensive neurologic exam, fundoscopic exam to look for papilledema and just any trauma potentially there that happened with the injury. Don't typically see that, cognitive and memory testing. We do that kind of similar to what you might find on the BESS. We do a vestibulo-ocular motor screen, so we do VOMS testing, and we do a BESS test. And so this kind of helps us to pick up. And what I really like is this kind of vestibulo-ocular stuff, when we check kind of like saccades, and we check for gaze stabilization, because there might be nothing else on exam, and that might trigger their symptoms. And if I've got one thing in an athlete who's telling me they're symptom-free, and I know they're not, and I see that, then I can say, you're not better yet. And that helps. It might help the parent more too, just to see that. So outside of the exam and that piece, then what do you add these other things like imaging? So most of the information about acute neuroimaging happens from an ER standpoint. I would say that most of my patients don't present, like I mentioned in our study, don't present like to me the first day or the second day. They're usually presenting several days out. So in the ERs, like this PCARN study, which is a huge consortium, this huge network called PCARN, that many pediatric ERs that are involved in that, including children in Wisconsin, you can see that this number of 42,000 some athletes or some patients that present at those hospitals with concussions or head injuries is a pretty good study. It's pretty good research here. So the ones that really were more needing CT scans in that first acute window were these: less than 15 GCS, abnormal mental status, sign of a skull fracture or basilar skull fracture. And you see with that about 40% of that study population. So these are fairly severe injuries. And a 4.3 risk of a positive finding, a clinically significant finding, which could include like a skull fracture or bleed. So definitely a CT in that situation in the acute setting. Now, if there's LOC or MSIS, repetitively severe headaches, severe mechanism of injury, that was about 27.7% of this population, and they had a 0.9% risk of clinically significant findings. And so this is the group that you can kind of observe versus getting a CT, you talk about it with the family, you decide what to do, but in the ER, right? And then last, none of the above, this is the most of the population, and in this group there was such a low risk, less than 0.5% of a clinically significant injury, again, bleed or skull fracture, that you really don't need a CT in those cases. So that's been really good guidance, I think, for clinicians to make sure they're not getting so many CT scans. So for me in clinic, when to get an image? Well, CT's rarely for me. If I think I need a CT scan, I'll probably send that patient to the ER, because I just think that if I'm going to wait, I could probably wait a day or two to get an MRI if I'm comfortable and I have a good exam, and if I don't, then I probably don't need to sit on that and just get them sent in because they might need some help. And then I can think of, in my practice, I've been at medical college for 6.5 years. I've had one patient who had a bleed and needed to have an emergency, drain put in and was in the ICU. So it can happen, and you have to look out for those things, like subdurals especially. So for me, mostly it's MRI. MRI is used largely in my setting, and sometimes I've had to do MRA, MRV if I'm thinking more posterior circulation or some kind of a vestibular or like a artery dissection or something along those lines. Usually it presents in a much more subtle way, though, as it presents in my clinic. And then all these other things, which we've been saying for years, at some point will come into more clinical use, is still kind of research-based. So then we also talk a little bit about computerized neurocognitive testing, and that really is something that we use as an adjunct. It's not a good way to diagnose concussions, but we use it, and we sometimes have to throw that in there if we have these more unclear situations. But most commonly what we use it for, as you kind of see here, our philosophy is that we use it for those patients we're trying to catch, and we only really try to use it as well when someone's recovered if possible. So if we have someone at the baseline and they've gone through their process and they're now saying they're symptom free, that's a great time to test. It's not really a great way to just test them every week, in our opinion, because it is cognitive effort, and it can also create like a real anxiety about taking the test. So we try to use it when there's a clinical decision to be made, and we also use it to try to catch kids that aren't telling the truth. And then the neuropsych evaluation is typically for the ones that have had either prolonged duration, so in those kids that are going a month or beyond in symptoms, or for the ones that have had multiple concussions, where we want to establish that the baseline of their cognition is good and normal and consistent with what they've done in school. And so we really like to use that. And this is where I have every Wednesday I have a clinic in Greenfield. That's where our combined clinic is, where we do these visits with our neuropsychologists together. And it really gives us a lot of input, especially if we're trying to make decisions towards 504s and IEPs. You've got to have the right neuropsychologist to do that. And so we have child neuropsychologists who have a focus on TBI and concussion that work with us. And it's because everything affects everything. It's really can be hard sometimes to know why someone's not getting better and what's going on, and that really can give us some clarity on how to treat that patient, how to manage them. So, in general, what we recommend after a concussion, especially in the acute time frame, is to decrease screen time. You might say you think that's interesting that I put in there the first-person shooter games, but just think of like car sickness on steroids. If you're like, there's one thing to be said about the violence in video games and all that stuff too, but this is really more about like, it's going to make them really sick if they're trying to do that and really stimulate them, so try to have them avoid that stuff. And, the phones, I think, are probably second to that, the biggest problem. They probably overall are the biggest problem just because of the overall use and how much kids are using them, but we try to avoid that. We want them to try to get better habits than they probably normally have, and good sleep, diet, and hydration. We think better sleep leads to a faster recovery. There's been some mixed evidence on that. Our own Dr. McRae and his group has found that there was a study that showed that better sleep, longer sleep versus shorter sleep in collegiate athletes, it showed that they had the ones that slept more had less symptoms. They weren't as severe, I guess you should say, but they all got better at the same time. There's been other studies. There was a big retrospective sample that showed that people that didn't get as good a sleep actually took longer to recover. So anyway, more to come on that, but we do think that better sleep leads to a better recovery, a faster recovery. And so try to get that consistent. And like I said about the drunk driver piece, you don't want them out there driving when they're concussed. Headaches, most of the time it's just because they're doing too much that their headaches are really out of control. They're going, they can't play, but they're going to watch their basketball games and it's loud in the gym. They're trying to like play the tuba or whatever they're doing, their drums, and it's just they're doing too much. They're trying to, take finals. As long as we can try to get that activity down to a level that's comfortable, we usually can get it better to a point that they're pretty comfortable. I think Tylenol is a good place to start, acetaminophen, because it's probably, just no theoretical risk of bleeding there. But I really use a lot of NSAIDs because I think they work well, and ultimately when they come into my clinic, like I said, they're days out, and I use it. But you really avoid narcotics, you avoid anything that is has that addictive potential. I don't think it has a good place in concussion. There's other adjuncts and other things you can do as well, but I think that kind of hits it. Emotionally, you're just trying to really stay on top of that. You're trying to dig in a little bit and trying to understand where this is going to go, because it can get out of hand in a hurry, and people can have emotional reactions with their concussions, and before you know it, they get pretty depressed. So Return to Learn, we have some really good guidance. There's a nice article out of the Pediatrics Journal by Mark Halstead, who I know personally. He did a great job on that. So if you want to pick that up, it's Pediatrics. And so it kind of guides you through the different stages of academic adjustments, like we call it the academic progress, like adjustments versus accommodations and so on, and helping you when you need to get towards a 504 IEP. I think the big key is you don't have to be 100% recovered to return to learn. If you're feeling good enough to be at school, in the acute time frame, it's probably okay to go. And you just have to make sure that that athlete's really well supported, that student's well supported. Communications, just communication with the school is so important. So I can't stress that enough. This is from the Berlin statement. It gives a little guidance, just very simple guidance on return to learn and kind of what it should look like. It's pretty commonsensical. You know, if we can start like those first, 24 to 48 hours or so of just trying to, create more rest, a more restful environment, and letting them do things at small intervals. And then if that's going well, they go back to school, they start doing more of their homework and things like that, and then they build from there. And so it's nice to just have that. And then, I think it's important, even though there's been some research that shows that, the kids stay out of school like, too long, or don't do academics and cognitive activities too long, or physical activities too long, it's still important that they have rest at the beginning. And so I do think that most athletes and kids, we're probably going to need, a day or two, maybe 2 to 3 days, just kind of away from the whole thing to rest and recover. And then you focus on when they get back on these key points that I'm going to go through and work them back. You work them back partially to full. And usually over a week's time, they should be back to full days and hopefully have their head above water and start getting back into things real well. So homework, we do all of these things as much as we can. We try to take each patient individually. The worse they are, the more acute they are, the more they get. And then for testing, we try to also make sure that we're not making them do things they shouldn't have to do when they're concussed. That's going to prolong their recovery. For classes, there's some things that are really truly unsafe, like shop class. PE class is something that we try to keep them in a study hall if we can, because I can't tell you how many times over the years I've seen someone with a concussion who went to PE class, and at best, they were there and people saw them sitting out and it was negative. At worst, they got hit by a stray basketball and it took another week or two to get them better because they felt bad again. So, and then it's just wasted time, it's time that they could be catching up on things. So I really try to push and advocate for those students, and if the school needs to talk to me, then I'll talk to them about it. Computer class, music band, so you would try to avoid really stimulating environments at the beginning. So moving on to return to play, return to sport, there's an updated statement on this too in the Berlin. And so this is just kind of what I would call normal. Baseline symptoms for 24 to 48 hours, off medications, normal physical exam, normalized computer testing, back to normal school. So that's an athlete that's really ready in the acute phase to start beginning this. And so I sometimes drag my feet a little bit, especially the younger the kid is, because we know that the research is trending towards recovery takes a little longer in kids. But, by the book, if you've got, a kid who's doing well, it probably takes them about a week to prove himself in school. Now you take it almost another week to get them through this process, then you're hitting around the 2-week mark and you're probably good. But just make sure you take it at the pace that you need to take it. So this is what it looks like. So you can see that stage 0 that I kind of made up is before stage 1. And then stage 1 would be symptom-related, symptom-lifted activity. So I put them, say, on an exercise bike and just say, or walk around the block, 15-20 minutes of low aerobic activity. And that's good because they need a little physical activity, and there's more research coming out all the time showing that early exercise might actually improve recovery. So there's the stage 0 I was kind of referring to, and then you build your way back up. And then ultimately, if their symptoms are on and on and on, and we're getting to that 3 to 4 week mark, okay, that's where I'm starting to talk about that pushing. So I might actually have to start pushing their physical activity a little bit because they're starting to get into this prolonged recovery, and that might be because they're a kid who runs 20 miles a week and they just need more physical activity. Maybe psychologically they're just totally bummed that they're not doing anything. So don't know, but we're seeing that sometimes we need to jumpstart the system, and that's only for the ones that just aren't getting better over those after those 3 to 4 weeks especially. So ultimately these athletes do need clearance, and you kind of have to decide when you're going to do that. It depends on the time course, it depends on the family, but the family needs to know that they have to be symptom free and they have to follow the protocol before they're going to get cleared. And so I'll have them call in sometimes for me, sometimes I'll make them come in before they actually return to contact to step 4 or 5 depending on which return to play statement you're looking at. So here's what we do for those athletes who are just not getting better, for those students who are not getting better. So physical therapy, there's all sorts of things we can do. I think that mostly we focus on the VOMS, the VOMS type things, but neck-related pain and cervical strain can really impact the resolution of headaches. There's an IU valve that can really come in handy if we're not seeing improvements, we're having difficulties with breathing. We'll find kids that that need glasses. We'll find kids that are having some issues with convergence. Psychologically, this is why we have a sports psychologist on our team, because you feel like if you don't have that spoke on the wheel, you're really not treating patients well. So our psychologist does these things, and it really can help. Some kids just can't cope with the restrictions or the injury or everything else that's going on in life. And there's the other things too that, sometimes in more difficult cases where we're just not getting better, we try to. So prevention, move on to that, see how we're doing here. So we'll try to get through this. Unfortunately, I don't have a ton to give you about prevention. I wish there was more. As far as football helmets, soccer headgear, mouth guards, there's really nothing reliable that you're going to find in the literature that's going to say if you do this, you will definitely have less concussions. And I think the football helmets, we know technology is increasing whatever it is, if it's our cell phones or our cars or everything. Technology is improving products and things are getting better. But we haven't found a concussion-proof helmet. We haven't found soccer headgear that really makes a big difference. We haven't found mouth guards that clearly improve things. So I think that that's just something to be wary of, because you're going to get a million questions about that. And if I get this helmet, will it keep me from having a concussion? And my answer is typically, well, if you feel like you have the money in your budget to spend it, and you want to get better technology, you sure can, but don't think that's going to save your kid from having a concussion. So rule changes.
Regarding the helmets,
yeah.
Why was Alpine and bike helmets? Do you have any clue why that was?
So it's really an interesting study. We put it up there because I think it kind of stimulates some discussion. It's a different thing, right? So if you just have like a single fall, and you wipe out, yes, you're protecting that brain, and it appears that improved, head injury severity and so forth. And so some people didn't report, but they weren't also going through the same protocols that the athletes were. They might have showed up in the ER with a closed head injury, and had a helmet on, and they were fine, and whatever. You don't know how exactly the follow-up went. But yeah, I think it's really interesting. I think that we might get to a point at some point where these types of equipment will show a decreased rate, but there's something to be said for the fact that the brain can move inside the cranial vault, and you can't. How do you prevent that completely? Good question, though. I wondered that same thing myself. So the other things that do seem to really be making a difference is the rule changes. So whether you're looking at youth soccer about heading, whether you're looking at pee-wee hockey, with like checking rules. If you're looking at decreased kind of exposures, that's kind of the big thing here with football. All these things seem to be making a difference. Especially you look at the decreased contact over the weeks, of practice, seem to be making a big difference. And so you can kind of see, the difference that's making. So at some point though, you completely change the game. So that's where the big question is, like, how much contact do you limit? And there's the side of things that if you don't know how to hit, and you don't know how to take contact, then are you at risk for a worse injury than a concussion? I don't know. I'm not really on that side of the equation necessarily, but it's definitely another counterpoint. And then if you look at coaching and technique, this is really important too. You got to make sure that they're doing things the right way, that they're safe. You all probably remember, the change in the spearing rule that happened in NCAA football. I think it was in the 70s, and that dramatically changed, the number of severe C-spine injuries and death that was happening out there. And so making sure that people are tackling the right way, whether it's the heads up from CDC, making sure that things are being done the right way, I think can make a big difference too. And coaching, goes much beyond that, but I think that that's really important. And then that positive culture, which comes from not only the coach, but from the family and really beyond. I think all of us have to create that positive culture. But if you look at it more from like that coaching perspective, if you can start that culture of safety with your team, you can talk about how important it is at the beginning. You can check in, how are we doing this season? Are we being good sports? Are we doing the right thing? I think that all makes a big difference. So if you look at the future, we got a lot that's going to happen, I think, but it's hard to know exactly where this is all going to go. I think more rule changes because it seems to be working, more age cutoffs, again, the new equipment that's just going to come, the tech gadgets. There's studies on accelerometers and EEG, systems, eye tracking systems, balance, blood tests. That's crazy. I listened to a recent talk on blood tests at our symposium, and there's so many, and they some of them are good in the acute frame, and some are in the subacute, and some are in the chronic, and I'm sure there's a lot of, you know, kind of jockeying going back and forth as far as like who's is going to, you know, be accepted and what's going to be paid for. And I mean, this stuff isn't ready for prime time yet, but that's coming down the pike, as well as genetic testing and all that. Advanced imaging as well. It's hard enough sometimes to get an MRI approved. We'll see how that all goes. And then our management, it seems like all the while, has become more conservative. So we're learning more, we're being more conservative. I think that kids' brains are being protected better and better, but sometimes we wonder if the pendulum swung a little too far. I guess, you know, better safe than sorry. Big kind of, we just want to hit home with this is that there's a huge need, continued need for awareness and education. I touched on it briefly already. But these are just studies that really show like the great need for awareness about concussion and, you know, these different sports. So just know that, you know, we're not there yet. We need to keep educating. There's still a lot of myths to debunk. And these are some sites to look at for education: NFHS, CDC, the WisSportsConcussion.org. So those are some good things. Want to make sure we keep emphasizing that culture. We want to continue to advocate for kids. You know, that's a challenge. I do have families that come in and, you know, they have their 12-year-old competitive athlete and they start talking about things and they're like, well, it's his decision. I'm like, no, it's not. It's your decision. You're the parent, you know. So I think that ultimately when it comes to things like concussion, it is, you know, and I think we've got to be an advocate for, you know, our kids, because it sometimes does get a little mixed up because, you know, why wouldn't it? I mean, if we look at like where the culture is with pro sports, why wouldn't it get a little bit mixed up? And so we have to bring it back to common sense. So briefly, here's our clinic. I just want to give a little plug for that. And, you know, for example, we're a multidisciplinary clinic, and certainly this could apply, I think, to other ones as well. But here's what we offer. We have sports doctors like myself, Dr. Walters started our program, and the others, and we have our advanced practice provider, nurse practitioner, April Benoit. We all see concussion. And then we have our neuropsychologists, we have our physical therapists, we have our psychologist, Dr. Mervick, and our athletic trainers. And so we have a really good true multidisciplinary team. Our typical visit types for the more acute injuries is going to be a medical provider and an athletic trainer working together. For those that are more of the complex variety, multiple concussions, a long recovery, we're going to do a combined visit with a neuropsychologist so we can establish where they are cognitively. And then we also potentially work in kind of a medical provider, LAT, and a psychologist. We're really thinking there's not cognitive issues so much as there's emotional issues. But that doesn't typically happen until after we've seen them initially. And so we really do work as a team. We discuss what's going on. We come up with a plan together. And I think that that's unique. And so who do you refer? Kind of like I said, the acute injuries go to medical provider, essentially LAT, and then the multiple go to the combined or complex clinic. And so if there's any questions, you want to try to get a patient over to us, you have questions about just, you know, anything. We have athletic trainers working our concussion line 8 to 4:30 every single day of the work week. So that's what we've got. We covered a lot of stuff. I try not to go too long. I think I went a little over here than I was going to plan to, but we covered a lot. You got red flags to look out for. Remember to when in doubt, sit them out. That young athletes take longer. That's always a big one. And we want to make sure they're back to normal before we send them back to play. And ultimately, you know, we're kind of like a little stuck because if we want to continue contact with collision sports, we're going to see concussions, but we can't prevent them completely, so we'll just try to do our best. So let us know if you guys need anything. We want to be a resource for you guys. We get excited about what we do, and we hope we're making a difference. So anyway, I saw a question back there, so thanks a lot.
Can you talk a little bit about your approach to the decision as to when a child is no longer eligible
to play? Yeah. Yeah.
Like
So.
that free for concussion, mom wants
Good
to
question.
say no more.
Yeah.
How do you make that decision?
Well, I wish I had a clear evidence-based algorithm. You know,
Yeah.
that would make my life a lot easier, make everybody's lives a lot easier. It would certainly create more peace of mind, I think. But there would be certainly arguments, I'm sure, over it if there was one. So I usually try to look at the number of concussions, the severity of the most recent concussion, and of course concussions before. You know, the duration, the impact on the kid. There's just kind of like so many different things that go into it. You know, what other potential comorbid or pre-morbid things they have going on. And I use that. So if it's a younger kid with more concussions that are more severe, I'm more likely to say, we need to sit out for a while. And a lot of times I'll start with that. Like, okay, we need to sit out for a season, or we need to sit out for 6 months, or we need to sit out for a year. I think the old tried and true was 3 concussions in a year, you're done for probably a year. You know, 2 concussions in a season, you're done for the season. But that's not like really that great as far as evidence, you know. But so I kind of use some of that, especially in the high school athletes. But if you're under high school and you've had 3 concussions, you're sitting out for a while. You need some time off. You need some symptom-free waiting time to hopefully not get a concussion. And that's because that's the only thing I can really do. And it's tough. We have a lot of these are never short discussions in clinic. You know, these are those that we talk about it with a family. And there's been times where I have that kid who, you know, they're just not in a really great place right now with where their mental health is. And the risk of them not being able to participate in something might be actually, for mental health reasons, might be higher if I hold them out than if I let them play. It depends on the sport, you know, and it's tough. I mean, every year at the MCW Sports Symposium, my partner, Dr. Walter, does coffee with the professor, where he talks about concussion, you know, the art of it. You know, the art of it. And I think that's really what it is. It's more of an art. Hope that answers your question. But I think 3 as a number is probably where everybody's mind goes. But 3 in a 12-year-old is so different than 3 in an 18-year-old. I have plenty of people that are at the college level who've had 3 and are still playing. I have less who are 12 and had 3 who are still playing. It is what it is. Any other questions? Yeah, that's a lot of information. Everybody's probably tired.
We're going to transition over to Noah.
Sounds good.
For those of you who don't know, my name is Noah Eckel. I'm one of the athletic trainers here at Watertown Regional. I cover Luther Preparatory School. I also go out to the Trek Clinic in Waterloo. My other 3 athletic trainers are here. We have Melissa Monroe, athletic trainer at Jefferson, also athletic trainer at Trek. Amanda Bakeso,
Yeah.
athletic trainer at Lake Mills High School, and then Amy Krishik, athletic trainer at Watertown High School. John is still with us as well, but he transitioned into Dr. Roman's office, so he's here. He covers Watertown, but only a couple days a week. Amy is the one who covers mostly. So we're going to go over some things from basically from our perspective, from the athletic trainer's perspective. Going to talk about the Headstrong insurance that the WIAA offers. I don't think the WIAA has done a very good job promoting this. Concussion statistics from our organization, concussion management, how we manage concussions when we see them, some things that we're working on, and then issues that we've come across this year. First thing I want to talk about is Headstrong insurance. How many of you are aware that the WIAA has an insurance that covers concussions? Anybody? Anybody? Okay. So, WIAA, starting this year, starting the 2017-2018 school year, has purchased an insurance. It's called Headstrong Insurance. What it is, it either acts as a supplementary insurance to that athlete's primary insurance, or if that athlete doesn't have insurance, it acts as that athlete's primary insurance. If you have an athlete that sustains a concussion participating in a WIAA-sanctioned sport, whether it be practice or game situations, this insurance will cover any bills having to do with concussion management in terms of medical bills, doctor's visits, physical therapy, anything at all that has to do with the management of the concussion. So even the concussion clinic, as a matter of fact, that helps to cover that as well. Couple caveats there. First of all, you have to file a claim within 1 year of the sustained concussion, and it doesn't cover club sports. So like the lacrosse club here in town doesn't cover that. Unfortunately, it does not cover dance and cheerleading. It should, but it doesn't. For more information on it, we did put the website there. It's a little bit long to see. You can Google search Headstrong Insurance WIAA, and it will pop right up. Otherwise, there is information and forms that are available in the athletic office at each of the high schools, and it's also on a lot of the high schools' websites. Yes?
And then I just wanted to say, I've had an athlete who's actually gone through this process. There's a letter to the provider, they handed their form in, they submitted their form, and it was very easy. It was a very easy process, flowed really well. It's not that difficult.
No.
It's very easy to use.
It's really nice for us too, because every once in a while we'll run into patients who will say, well, do we have to go to the doctor? Can't we just see you? And it puts us in a tough spot, because really that doesn't fall in the athletic trainer's scope of practice to clear concussions. So that's really, they really need to be going and seeing a primary care physician.
Takes
Okay.
that hip out of it.
Couple of stats to go over. So, common statistics for the 2017-2018 school year. Like I said, we cover 4 high schools total. From August 1st of 2017 until now, we've had 58 total concussions at the high schools. 32 of them coming from football, 9 from soccer. We've only had a boys soccer season so far. Girls soccer starts in spring. We did have 1 girls soccer player who sustained a concussion during off-season training. Boys and girls basketball combined 8 concussions through the high schools. Wrestling at 2, gymnastics 1, swimming 1. Non-sports related, we have 5 of them. 3 of them were from Phi Ed class. One of them, kind of that Dr. Fair scenario that he was talking about. We had a girl recovering from a concussion, sitting on a sideline, taking stats for a basketball game. She got hit in the head with a stray basketball. Concussion symptoms came back. Another girl was I believe she was a manager for the football team at Watertown. Basically, she fell off a gator while bringing supplies out to the field, sustaining a concussion. Let's see here. This thing, there we go. 2018, so same thing. So five of our concussions out of those 58 went to the ER due to red flags. Most of them were deteriorating condition over time. One of them was a loss of consciousness, ended up with the ambulance right there. 5 were return to activity. Return to any athletic activity was greater than 30 days. 1 has yet to return to play. I think she's 60 days out. 5 that resulted in termination of season. 1 that resulted in termination of athletic participation. Of those, 1 was seen by a neurologist. 4 went to the UW's concussion clinic. If you take those 30-day return to play out, the average return to play for concussions was 10 days. Obviously, you put some of those other ones back in there, it's going to be a lot higher. Symptom scores, as far as common symptoms reported, were fairly consistent with Dr. Fair's statistics. Number 1 symptom reported was obviously a headache. So acute concussion management, what do we, when we have a kid that we suspect has a concussion, what do we as athletic trainers do? Okay. First thing we do is we rule out the red flags, so any loss of consciousness, kind of the red flags that Dr. Fair was talking about. Loss of consciousness, cervical spine pain, radiating pain, severe balance deficiencies. Monitor for deteriorating condition. If that condition of theirs deteriorates over time, we send them to the emergency room. We do a pupil assessment, do a 12 cranial nerve assessment. Not that anything ever pops up from those, but you want to check those just to make sure. We do use the SCAT-5. We have an EMR that has the SCAT-5 built in, so we can use iPads, we can use iPhones to actually do the SCAT-5. Nice thing about the SCAT-5, besides the symptom assessment scale, it's got the best scale included. We do have a paper copy that we send with away athletes. We usually give it to the parent or coach. You never want to give a paper anything to a concussed athlete because Lord only knows where that's going to end up afterwards. We do exertional testing with athletes, so 5 push-ups, 5 steps kind of thing, if it's appropriate. If we have an athlete that on the sidelines reporting multiple symptoms, we're not going to do exertional activities with them. If we get the athlete that is staggering off the field on the sideline, comes to you and says, I feel fine, that's when we're going to do exertional testing, just kind of rule out the liars. Or we get the athlete who complains of a headache and dizziness, but it went away after 10 minutes, that's when we're going to do the exertional testing. Side note here, all of our suspected concussions are going to be referred to primary care. It's, like I said, it's not in our scope of practice to clear concussions. So all of our concussions, even if they cleared that day, are still going to check with the primary care. We do use impact testing. Dr. Fair kind of touched on it. Basically, we baseline test all of our incoming freshmen and juniors in the sports of football, soccer, basketball, wrestling, and gymnastics. Athletes who want to get an impact test, which is that computer baseline, we can do a baseline upon request, and we do it free of charge. It's not something we use immediately. It's not something we use once we find out, unless the primary care physician wants us to use it right away or requests us to use it. It's not something we use right away. It's usually something that we use once we start the return to play criteria. Let's see. Touched on the SCAT-5. Like I said, we have it in our EMR, so we use it. We can use it on our cell phones and as well as our tablets, and then we can just email that to the doctor right away once we have doctor's visits set up. Let's see here. So return to play protocol, yes.
Question about the impact testing. How much do you believe the results? I understand there are athletes already understand
that is a very good question. So 2013 Journal of Athletic Training did a study on the test-retest reliability of impact test, and that study wasn't so favorable for impact. It's a tool. It's a great tool, but it's only a small portion of the whole management of return to play, return to learn guidelines.
Yeah, I mean, I think, the stuff, the literature that comes out of their own, I mean, it is peer reviewed, but, they're typically more favorable in their assessment of their tool. I think it, like you said, it's a tool, but it just so depends on how the athlete or that person was doing that day, like, where are they at, mentally, how was it, they have a bad day at school, did they get poor sleep last night, did they get in an argument with their parent before they took it? I mean, all that stuff impacts how they do. Even test-taking strategy impacts it. I've had patients where they're the person that checks their answers like 5 times, before they go turn their test in, and they can do really well on their memory, verbal memory sometimes through the roof, but then their processing speed's off, and it's just simply because of the way they took the test. And yeah, so there's a lot of factors that go into what makes a good test, and as long as you control it the best you can,
right.
use it as one other piece of information, I think it's okay.
Yeah, like you said, I mean,
Yeah.
you have a teenager who's arguing with his boyfriend or girlfriend that day, they can also throw that test off as well. So there's a lot of questions regarding that test-retest reliability for that. So like I said, return to play protocol, it's identical to our position here at the hospital. It's identical to WIA's protocol, and it's consistent with the Berlin statement. Once again, all athletes with suspected concussions are seen by primary care physician immediately after concussion. Once the athlete is symptom-free for 24 hours and able to complete a full academic schedule symptom-free, that athlete may return to the steps to return to play with primary care approval. That sounds kind of redundant, but you'd be surprised how many times we talk to an athlete and they're like, oh, I feel just fine. Okay, well, how'd you do at school today? Well, I had a little bit of a headache towards the end of the day and had a little bit of difficulty concentrating, but other than that, I feel great. So this is kind of, yeah, it's a redundant thing, but it's something that we have to kind of tell the athlete and the parent as well. Each step is 24 hours apart, and if that athlete has symptoms that return, then we'll repeat the previous step. Our steps are pretty much the same as Dr. Fair's. They're just numbered a little bit differently. So our step, yes, sir.
Is there a minimum interval before return to play is even allowed?
That's kind of, it's going to depend really on the athlete.
So what I'm thinking is if most students require at least 10 days for beginning complete recovery, would it not be unreasonable to mandate, say, a 2-week minimum before even consideration of return?
Sure.
So many parents come in and it's, well, my kid I think is ready by Friday this
Oh,
week,
yeah.
and you're
and we run into that all the time.
Introduce them to the need that it's a graduated return.
It certainly wouldn't be a bad idea to have a set guideline as far as that goes. We don't right now, but I know we deal with that on a regular basis. Yes, Melissa.
So if I have an athlete Friday night sustains a head injury, the idea is that I will see them again Monday will be the next time I see them. They have to be 24 hours symptom free before I will begin anything. So if they come in Monday symptom free and they said they were symptom free on Sunday, I'll kind of waiver that. Do I trust that athlete? Were they actually symptom free yesterday? So either Monday will be my first day that they're symptom free, or I might make it Tuesday because they told me Monday was the first day. So symptom free is the first step, or step 0. Then after that step, we need to follow up with the primary, and then after that step's done, we can take the impact test. We could take the impact before then, but those are the 3 things that need to happen. They need to be symptom free, follow up with the primary, and have the impact done before I will begin my first day.
Yeah, but that's consistent.
I think that's all great, and the
Yep.
return is very appropriate, but it would be easier if there was a mandatory 2 weeks to cool down.
Sure.
And the parents understood that
Yeah.
from the front end, and the student did, and then I'm not pressured to try to
Right.
accelerate the return.
And usually with what we do as well is when we have a kid who sustains a concussion on a Friday night at a football game, we automatically tell them, you're not playing that next Friday. So we try to take that expectation away from them. I realize it doesn't happen all the time, but we try to take that expectation away from them.
I would say 2 things. One, it would be great too to also include, if it's a Friday, make sure they get through a normal day of school on Monday, Tuesday potentially, to make sure that's going okay. Because if they say they're better at 8 a.m. on Monday and they haven't gone to school yet, that might be a little early to start it. If it's after school, you can talk to teachers. It's always good to build in a little more time, and I think we might get to that point where there's a more mandated time. But there are a fair number of these injuries too that, one, they really look like awesome. One day later, it's like the mildest of mild, and you got an 18-year-old kid. So you don't know, what to do sometimes, but I think that in general, more time is better. That's like I said, sometimes, we'll try to slow the process down a little bit and try to get across to that highly competitive family, we'll just say, that we've got a lot to worry about, and we want to make sure that if you are going on with this, that you keep yourself safe for the here and now and for the future whenever you're an adult not playing sports. And so it usually goes over pretty well, and I can get closer to that 2-week time frame. So, yeah.
All right. So like I said, the steps are pretty consistent with what Dr. Fair showed before. So depending on the primary care, patient has to pass the impact survey prior to step 4. Some of our physicians like to get a few steps in before they take the impact survey. And then depending on physician's order, they may need to be seen by the primary care prior to step 4. Some of our physicians just want us to keep constant contact with them prior to step 4. Some of them want them to come back before step 4. So it really depends on the physician on where we go with that. Constant communication with primary care is key for us, though. I mean, every step of the way we're contacting the primary care, whether it be Tiger text or email, just kind of letting know how everything's going. So, return to learn, that's kind of a weakness within our organization. We admit that. It varies depending on school. Varies depending on physician practices. A lot of physicians have their own return to learn program. Currently, 2 of our schools use the academic accommodation guidelines from Impact as their policy. Basically, it's just a sheet that has kind of a check off that says that belongs to the physician, that says what this student can do for school. One of our schools does have a little bit more in-depth one, but it's a similar policy to that. Issues we've run into in the last year. So, had some issues with miscommunication, misunderstanding of return to play guidelines. We had, and if you 3 want to speak on this, that would be great. We had a patient who was seen in the ER and was diagnosed with a closed head injury, even though they clearly had concussion symptoms. And the athlete didn't understand why they needed to enter return to play guidelines at that point, as well as the parents. We had an athlete that went to urgent care that was seen on a Monday and told that they can participate in sports again on a Saturday. We had, and once again, the parents were upset that athlete was put into the return to play protocol. We've had issues with inappropriate providers. We've had athletes that have gone to see physical therapists and chiropractors for their immediate diagnosis of their concussion, as well as return to play. A couple of years ago at one of our high schools, we had a chiropractor tell a kid that they needed to keep their, was it the right side of their head? Okay, so they needed to keep their right side of the head closest to the wall because their concussion was on the left side of their brain, and they needed to keep their right eye closed during school. Had some issues with old school mentality. I had a coach yesterday, I had a concussion that happened yesterday. I had a coach tell me that we have the most faked concussions of any school around. We have coaches that will make excuses still for concussions. I told that coach, by the way, that he's wrong. And then we have an issue kind of going on at Jefferson High School right now. I'd rather have Melissa explain that than me.
Yeah, so I'll see that. So we have athlete comes out of the game exhibiting signs of a concussion. Upon asking, through the eval, memory is good, no amnesia, tells me 0 symptoms. However, I can see those symptoms, so I remove her from the game. Parents are always going to be upset, but Dad is very adamant. This person, she did fine on her evaluation, why isn't she playing? So this was very difficult. Going through the weekend, coming into Monday, Dad had seen a provider who said that he would clear this athlete for participation on Monday. And I explicitly said they need to see my notes. This person needs to see my initial evaluation because that was the determining factor to remove from play. Upon showing this provider those pieces of that document, they still continue to return to play. So as a whole, as all healthcare professionals, we need to be supportive of each other and our decisions. This provider happened to be a physical therapist who, there's the PTs lobbied against being a part of the healthcare provider and the state law. So some may have been trained in that area and some may not have been. So it's difficult for us to accept that as a clearance, to override the athletic trainer and come back to play early. So that's difficult. So moving on from here, I guess the way we can make this better is communication, is supporting our fellow healthcare providers, our healthcare professionals, in order to make the best decision in the athletes, for the athlete's best care. I think this provider was acting inappropriately and unethical by letting a athlete return to play early. They didn't have symptoms the following day, they didn't have symptoms over the weekend, they're acting normal, they can go back. And that's inappropriate. But that's something that is hard for us, especially when a healthcare provider has overridden us. We can't do anything else about it besides watch this young athlete's brain, this young athlete's life be dangling because of a decision someone else made. So that's difficult for us. So we can all work together, basically moving, just be a nice tight-knit community.
Yeah, I would say there, don't also make sure that you use the WIA to your advantage and pull it, make a process to pull that card.
Yep.
And so as I don't know who is fortunate, whoever is your supervising medical provider
Yep.
in that discussion, that you can make that, go to WIA and get that card pulled until they get another evaluation.
So what we ended up doing in this specific situation is we contacted WIA,
Yeah.
who was the person who said, well, healthcare provider, it could be a physical therapist because
True.
of the way the law is stated. So he said, if that healthcare provider is going to write that note and your AD is going to accept that note,
Yeah.
get in writing that your AD accepted that note, document everything, because this is an inappropriate call. But he said, you can't do anything about it if your AD is going to accept it.
So
You have to follow suit with that.
did the AD accept it?
The AD accepted it
So-
and has written confirmation of
So
it.
you at least, have covered yourself, from a legal perspective, but
But
it's not ideal.
it's not it's not so much about you, it's still about the athlete.
Yeah.
So it's still a very difficult situation.
Yeah.
So make sure as a provider you are contacting the athletic trainer, because a parent could come in and tell you everything you want to hear. Make sure you hear how the initial assessment was, because that would be a determining factor.
The communication is so key.
Yes.
I've had to pick up the phone before and just talk, to whoever it is, and just say, look, I have concerns. Do you want that, risk on your side? Do you really want to continue to move forward with this when I'm telling you I have concerns?
Yep.
Because and then a lot of people will say, okay, yeah, it makes me a little uncomfortable. But maybe we should talk about that. And but it's hard. These are tough cases.
Parents know.
We're gonna end here, and we can
Okay.
get copies of slides to anyone who wants them, so thank you everyone for
Right? Start your guns. I should have rolled up for my ancient side.
I have
I did, yeah, because the WIA representative told me, like, verbal is not enough, you need to. So is this girl practicing? Oh, she is. She's practicing. She's playing tonight. Sport. You know what? I know. It was really sad. Remind me this Tuesday.
These are really for families. So like you want to have them and use it. I'm going to say, Dr. Boxmeyer, where that is what these would be. I mean, you guys can look at it with this concussion line in the back or requirements and stuff, but a way to maybe encourage families to, like, you need to take this next step.
Okay.
And is there? Okay.